Good afternoon, everybody. What's going on?
What up? What up? What up?
Intro. Did y'all say our intro panel?
I was over here like,
let me tell you though, it's like right when you get into it, then it's like, oh yeah, we about to go on live.
Right. You start jamming. You hold up, I get back. I'm sorry. What's up, fam? Welcome to another week's episode of No Clue, guys. We back. We want to thank y'all for joining in with us. If you're joining us, say something in the chats. Share, like, follow. What else can they do? Download and donate it to people. Billy, what's going on? Good to see you, sir.
Oh, hey.
We got Billy and Kay. We got our two famous people. Welcome. So, guys, we're gonna get this party started. Billy, if you save that clip from last week, I will find you. So we told you guys we're gonna do a healthy share every week. So your healthy tip for today is before you eat your meal, drink a full bottle of water. It will help you get full faster so that you're not gorging yourself. We're trying to eat healthy, guys. Be healthy. And if you like me, I love some lemon pepper wings, some mild wings with lemon pepper seasoning, some honey lemon pepper wings, some garlic lemon pepper wings.
Come back.
Yeah, because I'm
that part.
hungry.
You lost me when
which one? No, so I went to Asaki, North Carolina. They had orange pepper wings. Never heard of it, but when I say they was banging, shout out to Asaki, North Carolina. Nobody knows where that is, but just know it's somewhere in the world.
We're gonna take your word for it, but
But we're gonna get this party started with our say what. So Terry, you up, baby girl?
Hey, wait a minute. We got a face that people don't know. Can we do the right thing?
I was gonna introduce him. I'm gonna get rolled up. Y'all won't see me next week. I'm gonna be suspended. They probably gonna fire me. But DJ, introduce our guest.
So, people, welcome to the show. Y'all know we love y'all. Thank y'all for your support. We are so pleased and privileged and honored to have Dr. Pete Thomas join us this evening. So, Dr. Thomas, I'm going to turn it over to you. Just give the people a little bit about yourself, your background, and then we're going to get into it.
Well, first, I just want to thank you guys for having me on. I feel like I'm part of the little circle here. I have to remember that I'm here for official business. I mean, I'm having a great time with you guys. You got me really relaxed. So I'm a general internist. I have been practicing medicine for over 25 years. Most of my career I spent at the Cook County Health and Hospital System, where I treat primary care patients, HIV medicine, as well as medication-assisted therapy. For those who don't know, that's a program to treat patients who are addicted to opioid drugs. In addition to that, I wear a public health hat, which drove my work with men. So I ran a program called Project Brotherhood. It's a Black man's clinic. And that was a very successful program that we ran out of Cook County for almost 18 years. So that's been very fulfilling. And then I went over to Near North and was the director of medical support services for them. And just excited to be here and see how we can help educate the community.
Thank you. And for those of y'all that don't know, Dr. Thomas and I are the people from Chicago. So now it's balanced out. So we got 2 people in the A and 2 people in the Chi. So
nice.
Right, Robert. Right.
I got it.
You're haters. I want to be a hater your whole life.
I just want to be clear. I got love for the A. I every time I go there, I have a ball. So hey, I can't wait to get back down there.
Come on, we don't have snow. Come on down.
We
hey,
don't.
Brandon, Billy, thank you for joining
DJ coming too.
DJ,
I detest Atlanta. Can I say it again? I detest Atlanta.
I have a ball in Atlanta. I ain't gonna even front.
on behalf of all ATLians, we detest you as well.
That's fine. That's why I live in Chicago.
In the famous words of our 66th mayor, Keisha Lance Bottoms, that ain't how we
Yeah.
take your ass back home. Billy, have a great night, sir. We'll see you next week. If I see that video on Twitch, Billy, I will find you.
That's okay. We love you.
Tilly, what's our say?
Say what?
There we go. All right. So our say what is give me your thoughts. So I don't know if you guys have watched or saw what's happening to the Haitians at the border.
Yeah.
Yeah.
Is that modern day slavery or what?
And it is. I'm not, and I like how our 46 came on and said that, that is unhumane. But still hasn't said anything about it happening when it happened in America. But I just think we should intervene. I think that's something we should intervene on. I think that's something we should step in for. That's a human rights thing to me.
And I mean, I would agree with you to that to a certain capacity, right? The problem is we live in a system that is based off of white supremacy. And let's be real, that is a country of quote unquote poor, underdeveloped, third world colored people. They are people of color, of African descent, Afro-Haitian, American descent. It's all the same. We are all from one same cloth. Ultimately, that's part of the entire crisis or part of the problem with any nation that isn't, one of the superpowers or European based by nature. So, we're going to get a lot of those things. But I agree with you. I think it is a basic human right, and we should take a stand to intervene at some point. But
do you think it will happen?
Otherwise. No, I don't. And that's what I was getting to. But I think our historical context has shown us otherwise.
Dr. P, what you think?
Yeah. I agree. I think that, to me, I look at this like a stress test. Whenever we're stressed, the real us come out. Us, I mean the US. And so no matter what we say on official documents and on the news, but when pushed to the brink, the real us comes out. And so we saw the response to these people of African descent, and when they need our help. And we did the exact same thing maybe 20 years ago when all the Cubans were coming here in those boats. And then when the Haitians came, it was two different responses. Now, the reality is there does need to be a comprehensive immigrant reform, right? So we need to really look at it and look at, okay, how will we be the sort of world savior or whatever? And how are we going to apply that, uniformly and not, have two different positions depending on where you come from? So I just think we got some soul searching to do, but we shouldn't be surprised. This is sort of this sort of been our policy all along, is that we're going to treat one group of immigrants one way and another group of immigrants another way.
One more question before we move on. Do you guys think that this is another form of distraction?
I hadn't thought about that, but that's a good one.
That is a good one, because it's distracting us from what's really going on in the Middle East, where we just pulled out of, and the Taliban has taken over. And yeah, I believe it is. It could be distracting us from a bigger picture.
Yeah, I don't know. I don't know. I'm on the fence with that one, because I feel like there is so much going on everywhere, right? And in the brink of a global pandemic, to add on top of the additional stresses that everybody has, I don't disagree. And you did make me have to think about it for a second. So I do appreciate that part of it. But I mean, I don't know if it's necessarily a distraction so much as this is just something else added on top of everything else. I mean, we're still seeing the effects of more hurricanes that are more category 3s and 4s across the Gulf and across seas than we've ever seen at one time. Precedented. It's a constant response. Like, there's always something that is occurring. And so I don't know if I don't disagree with you that it could be a distraction. I guess I'm just looking at it like this is just another thing on top of the many other things that we're dealing with.
Yeah, and also I think out of all the distractions, you don't want the distraction that actually makes your administration looks less competent, right? So I don't know that somebody would come up with a distraction that actually makes me look worse than what I did prior to the distraction. Okay, so it's already that the pullout of Afghanistan appeared to be somewhat not well thought out. And then on top of this, we got the immigration issue and people, crowding the borders in Texas. And then on top of that, you got the COVID-19 pandemic. I don't know that people would voluntarily choose that as a scenario.
Well, if grandmama were here, she'll say, we living in our last days.
Right.
or the other part, like people died and they never died before. My response to that was, well, I would hope so, because if they died and they coming back, I got a problem with that. Yeah, think about that for a while. Let that sit. Yeah, let that sit.
Never died before.
Yes, people are dying that they never died before. Yes.
So tomorrow at our staff meeting, I'm gonna say that, because we always talk about whoever has died. I'm gonna say, well, nowadays people dying that ain't died before. And so I know some of my older people are like, you right about that, baby. If they dead and came back, if Jesus left me behind, we finna fight on sight. I'm just letting you know. All right, so that's a lot to think about. Thank you, Terry.
That is.
Got something else?
No,
that's it.
How dare you make us think and have a deep conversation before a deep conversation?
Well, we had this panel on Sunday, and so I'm still in thinking mode from even just the panel we had on Sunday. So we got that coming back.
Yeah, we got a sidetrack about that. But all right, fam, we'll be right back after this quick commercial break. When we come back, we're going to get to our main topic. We're going to talk about HIV and education, guys. It's time to get educated. We're going to educate to break. We're going to educate you so you can break the stigma. All right, we'll be back. Shout out to Ricky Z Media, you guys. That's our production who produces this show. If you have a podcast idea, thought, something you just want to put out there, get in touch with Ricky Z now, because I'm telling you, once she blow up, you ain't going to be able to touch it, because we blowing up with her. All right, so get in touch with her now. Email her, Facebook, tweet, Instagram, Smoke Signal, Pigeon Messenger,
message in the bottle.
Chat.
Man, y'all going way back.
Do what you gotta do. Hear me what I say? All right, guys, let's get into our main topic. DJ, you're up.
So y'all know last week we talked about sex, and we kicked it off because that's what we know you all wanted to hear. That's what you guys wanted to talk about. So we wanted to make sure that we kept it in line. But keeping in line with that, we talked about a lot of things, and we've talked about this in passing. I've been very transparent with you all about my status, and we want to just get down to the nitty gritty and really educate people about what's really going on, especially for people that look like us. So with that being said, if we could pull up this map so we can kick off this hard convo. Or the diagram.
I know he said hard convo. I was like,
Well, no, I'm saying that because, especially for us, right? Because as we get into this really impacts us. Yeah. And so I want you all to see this so that we can start off having this conversation. So the chart that you see here is what's called the HIV care continuum. And this will be a perfect time for me to let Dr. Thomas take the lead, and I'll chime in as necessary. So can you just break down what we're looking at, Dr. Thomas?
Yeah, so this is called the HIV care continuum, and it's sort of the driving philosophy or model that we look at for designing programs and how we approach treatment and prevention. And so if you can imagine, there's 1.1 million people in the United States that have been diagnosed with HIV. Okay. Only 86% of those folks are aware of their diagnosis. So if you can imagine, that means there's about 14% of people who who are HIV positive who are not aware of their diagnosis. Of the 86%, of the 1.1 million people, only 60% of them have been linked to care. And there's specific parameters that we look at to say if you've been linked to care versus retained in care. And a large part of it has to do with how many times you've come in to see your provider. But so you can imagine, of the 1.1 million, only 62% of folks actually is connected to a place to go and get their care. And then of the 1.1 million, only 41% have been retained in care. Now, to be retained in care, you would have had to gone to your provider at least twice in a 3-month time period, or 3 months apart, in 1 year. So that's less than half of those folks have been retained in care. And then of those, of the 1.1 million, only about a third of those folks are being treated with antiretroviral therapy, which is the phenomenal medication that we have to treat HIV and to keep people strong and healthy and live long lives. And then of the 1.1 million, only less than a third, or about a third, is actually virally suppressed, which is our goal. The goal is always to get patients to be virally suppressed. In order to do that, they have to be on the antiretroviral therapy. So that is the sort of the starting point from which we have to start when we're looking at this picture, is how do we get people diagnosed, know their status, how do we get them linked into a place to go to get their care, how do we keep them there, that's retained in care, and then how do we get them on medications and get their viral load down to be zero. So that's our starting point that we try to look at. And I should tell you that the backdrop of that has to do with principles like the social determinants of health, which basically is social conditions that people find themselves living in. If it's poverty, if people are unemployed, racism, stigma, all of those things keep our goal from getting accomplished, which is getting to zero. So that's another principle that if you could just put right above this entire diagram would be SDOH, which is the social determinants of health. Those are the social ills that we find ourselves in as African Americans and Latinos, that racism and poverty and all those other things impact our ability to have a healthy outcome.
And, thank you for that, Dr. Thomas. But I would argue that the SDOHs are the bars before the bars, right? And so what that means is exactly what you're saying. All of those other factors are what impact what we're looking at here. And we're going to talk about some of them today. We're going to definitely talk about the stigma piece. We're going to definitely talk about, the moving across this care continuum and what that means and what that looks like. But ultimately, panel, what y'all think? How does this make you feel? Coming into this and this being the first thing you see, what are y'all thoughts? Doc, what you got?
Wow. Can I start there?
Yeah.
Wow. Because looking at this, so I'm fortunate enough to have healthcare, right, through my employer, and I complain about what I pay a month. So I can only imagine what people who have what their payments look like, or what their Medicare, what their medical expenses look like. That's what I'm looking for. But what this brings questions to me is, what is keeping people who are diagnosed from getting care? I mean, because I would think like when you're diagnosed with something, your first thought is, how can I stay alive? Or how? So the stigma behind HIV is that you're going to die soon. Okay. This comes from early 80s when it first became, rampant, and people's like, you got HIV, you're dead in 2 days type situation. That was the mentality, right? So, but now we know that people. Can I say a name? I mean, everybody knows, though.
No, don't use any names.
There's a celebrity who we've known has been positive for like 26 million years, right? So clearly, you don't get it and die. You can live a healthy, happy life, have children, and everything. So my question would be, once diagnosed, what's keeping people from getting in care?
So two things, because now I got to go put on my systems and processes hat, right? First thing is language, right? When people say stuff like those kind of things, that reinforces stigma. It reinforces what's called stigma by association as well as self-stigma. So those are two things that we want to keep in mind. Let's be mindful of verbiage. This is a virus, and we're going to address it as such. So that's number one. Number two, the other piece to that is, to your point, and we'll get into it a little bit more. Those social determinants of health are major factors. And even in this time frame, and I want to be very clear on this, that even in this time frame, there are people that, I'll use me for example. I've been very transparent about my status, so I'll use myself. If I wasn't in this category to be one of those people who was fortunate enough to be retained with a provider that was actually competent and practiced cultural humility and understood what I was doing, that I had access to antiretrovirals, I wouldn't be virally suppressed. But there are people that are like me that also have the same access, but because of stigma, and because of stigma specifically related to HIV in particular, they don't make it across this cascade. They get stuck probably at the point of most people, honestly, especially people of color, they stop at the point of diagnosis. Most people do not move across this continuum, which is why we see such sharp declines as we go across it. But I'm gonna save that pen for the next part. Arteria, what are your thoughts?
So Doc took the words out of my wow. But also this is very hurtful. And I say hurtful because the HIV and AIDS thing is very near and dear to me because I have a brother that lives with it. And so my mindset is, why can't we be 100% across the board? Everybody be taken care of. Everybody get what they need. Everybody have the support system that they need. You know what I'm saying? So, being so near and dear to it, my brother is one of those that is stuck at the diagnosed. He hasn't moved across the board. And he has his reasons of why he hasn't moved across the board, i.e. medication is expensive, i.e. he don't want to be marked as, that you're not going to live past a certain, so it's hurtful. It's kind of make me kind of speechless a little bit. If that makes any sense.
No, it makes perfect sense. And that's a great segue. If Dr. Thomas, was you about to say something before?
Yeah, I'm just going to, flip it for a minute and say, if we were talking about diabetes, if we were talking about high blood pressure, we wouldn't have, there's not the same stigma attached to those chronic diseases as it is to HIV. What I've found in my years of practice is that society, particularly our society, puts this blame on our HIV patients as if there's something that they did wrong. You follow me? And we don't put that same pressure on people who have high blood pressure, people who have diabetes. We don't say, shame on you for eating that jelly cream donut. You know what I'm saying? And so that also puts pressure. So now I have to deal with a societal judgment on me, as opposed to just saying, hey, I have diabetes and now I need medications, or I need to go into, to seek care. Like it should be as simple as that. But again, because of the societal pressures and people, and we talked about this before the show started, and all the societal norms, and we got people that want to put judgment on Nas X and not put judgment on these folks. And so it's all of that play a role in this. And then you add that on top of what DJ and I were talking about earlier, this whole social determinants of health, where a certain segment of the population is dealing with racism, they're dealing with lack of resources and lack of economic opportunities. And those things really are real barriers that says, okay, I don't really have a stable place to live. So right now, taking a pill, to do whatever y'all think it does, that ain't a priority to me. What's the priority is making sure I have something to eat and a place to live. So those things also play a role.
And thank you for that, Dr. Thompson. Those are major points, the contributing points. So I wanted to kind of touch back on what Arteria said and kind of say, so thank you for this, Ricky Z. You can pull this down now. Thank you for putting that up. Mm-hmm. But before we move forward, I do want to tell our viewers, if you have questions, please send them in the chat. We want this to be interactive. We really want to get your input and your feedback on this. So it's a lot of information. We got a great resource. Let's utilize it effectively. But to that point, when we're talking about stigma or misconceptions, what have you guys heard about HIV? Good, bad, or indifferent?
Death. I'm
Yeah.
sorry. If you have HIV, one, you're gonna die soon. Two, you're gay. You slept with a man who has HIV, or if you're a female, your man is on a DL, sleep with a man. Yeah, those are the two main stigmas I've heard.
Okay, Arteria.
Don't sit next to me. Or I can't hug you. I've heard all types of so like it's just crazy.
Yeah, and I wanted to bring that up because even in 2021, with all that we know, yes, Raphael, it's a gay man's disease, but even with everything that we know now from science and technology and just through basic research, you still hear people say you can't share utensils. You still hear exactly that people don't want to stay in the same place or the room with people. Some hospitals don't want to service us. There are ERs or emergency rooms that will look at us differently or funny because we present and you know that we have HIV. So even in 2021, knowing what we know is still that same stigma. What we're talking about now, and that's a great way to transition into the stigma component, because what is it? How does it affect them? Let's talk about it. What makes this particular stigma different?
Yeah.
What are your thoughts?
I think because HIV is a sexually transmitted disease. So for what that means, and I get it, there's other ones out there. You have chlamydia, herpes, syphilis, gonorrhea, super gonorrhea. Don't judge me. I thought it was a joke until I found out it was a real thing. Because I was like, "What are you like? I got super gonorrhea." But I found it's a real thing. So anybody who has had it, I apologize. I'm not making fun, but I thought it was a joke. But all of those, you don't hear about people dying. You don't hear about it being death, and it's not directly tied to the alphabet community. Whereas HIV, it is thought that only gay men can have HIV. And you're gonna die. Like you said, it's the 21st century. We're still living in the Pose season 1 and not Pose season 2.
We're gonna touch on that soon too. But thank you for that. Arteria, what are your thoughts? What makes this particular stigma different?
That's something to think about. Like, just a long educational to me, and I was educated on something, so that's something for me to think about.
Okay, Doc, Dr. Thomas? What are your thoughts?
Yeah, so it's interesting that. So I've been doing this for so long. I remember when we didn't have the internet and people were going on just pure ignorance, right? So they was just, lack of information. Now people are getting bombarded with information and they don't know how to delineate what's real and what's Memorex, if you will. And so I think one of the issues is that people put this sort of judgment on how patients become infected with HIV, as opposed to just saying, "Hey, this is my brother, this is my relative, this is my neighbor." It doesn't matter how. It's how can we take care of my neighbor, my brother, my sister. And so I think that's a huge problem. And you can even tie this together with COVID. And there's a lot of parallels here that people are listening to all of these other propaganda that has nothing to do with the price of tea in China. Is there a metal inside the vaccine? I don't want to get into that. That's for another show. Okay. But all I'm saying is lack of information and then bombarding with a whole lot of information, and people aren't able to delineate what's real and what's not.
Okay. And for me, y'all hit on it. I'm just going to highlight the 4 things that y'all talked about and kind of wrap it up in a clean, smooth package. So the first thing we talked about was public stigma, right?
Mm-hmm.
And public stigma is a public perception that, based off of stereotypes, that treats some form of discrimination or isolatory discriminatory practice against a particular person, set, or groups, right? And we talked about those things. We talked about public perception as it relates to sex. We talked about public relation and association as it relates to sexual transmission of HIV, being that is one of the main forms of transmission, right? So that's that part. The second part we talked about is the self-stigma behind that, which we kind of touched on, but not really delineated on. And that, people internalize it themselves. A lot of people living with HIV have not reconciled the fact that they are people living with HIV. And that's why you all have often heard me say, when we talked about, and I talked about my experience, that I don't live with HIV. HIV lives with me. I'm still in control of my life. And so my perspective is shifting and it's different. I don't let HIV control or dictate how I move and function in my day-to-day life. And many people are literally debilitated behind receiving that diagnosis, and it consumes them.
Mm-hmm.
And so then they start to internalize and reflect in all of those same negative components that have been projected on them from the outside. The third part to that is stigma by association, right? And what that means is that you look at it as the example of, like, if me and Dr. Thomas were going around, and now that I talk about myself, so like, oh, well, since he with DJ, he must have HIV too. No, that's not the case. But that then reinforces these same negative particulars that people don't want to then disclose their status or be transparent about it, because there are furthermore associated just by association. Now my support system is impacted by this, and now maybe they detach from me as well, which further causes me more issues. The last part is structural stigma. And we know what that is. That's the laws, that's the policies, that's the practices, that's our systems and processes, right? But that's exactly what it is. That we had HIV criminalization laws on books that criminalize people for transmission of HIV for means that you can't even transmit HIV through. In some states, those laws are still on the books. But we don't look at those other laws that criminalize people for involuntary disclosure of your HIV status, because it's a lesser penalty for that, but it's a larger consequence for that person. And so that public stigma, or structural stigma, I'm sorry, helps to reinforce a lot of those things too. And when you look at the whole picture, right, I'm losing on every point. Where do I have to go?
That's right. That's right. That's right. And so then that explains why we're not moving across that continuum. Explains why we can't get people linked to care, get people diagnosed. Some people say, I'd rather not know, because knowing now puts all of that on me, but I know that I might be at risk, but I'm willing to take the risk of dying without medications than I am to take on the burden that DJ just talked about, which is excellent, DJ.
So I just want to open up something that you said, D, if I can.
Go ahead.
And I like how I abbreviated your abbreviation, DJ, and I just called you D. But one of the ways that you can get HIV is sexually transmitted, but you can also get it through sharing needles, because you have a lot of people who do narcotics that you inject into your system, or you're sharing needles with other things that you use your diabetic needles and you want to recycle those and use them for something else. So by sharing needles, you also can transmit HIV, which leads me to, can I ask a question?
Well, and I just want to clarify. I didn't say it was the only way. I said it is the most common way.
Yeah.
So when we look at those things through epidemiological trends and we track those data through surveillance reports, sexual transmission is the most common way.
Yeah.
In fact, truth be told, if we look at intravenous drug users, they're the lowest risk of transmission, believe it or not.
Yeah. Yeah.
Learn something new every day.
Yeah. Well, and if you think about it, Doc, there's not a huge percent of our population that's using IV drugs, but guess what? Everybody almost on this planet is doing. They're having sex. And so if you think from that perspective alone, if you don't know nothing about epidemiology or anything, you just know that more people are having sex and less people are using IV drugs. Now, there's a certain percent of the population that does do that. And there again, a set of circumstances that surround that. condition also. That's what I also do. Another hat that I wear is the medication-assisted therapy for patients who are addicted to heroin. But not all heroin patients inject. Some patients snort, some patients smoke. But anyway, the point being is that sexual transmission is the highest risk factor. And with that, underneath that is all of the other sexual. So you have rectal sex, vaginal sex, oral sex. Oral sex it's a very low risk, but it is still a risk that you should be aware of. Also, another low risk is blood transfusion, and what else? Also, cuts and bites, but those are very, very, very low. So, but oral sex is near the bottom, and so is IVDU, which is intravenous drug use.
And just to clarify, blood transfusion is only a low risk in the United States because of our blood practices. So I want to be very clear on that.
Right.
But that's a good place to start. And that was a great segue. Who is contracting HIV? Who do you all think are the main people contracting HIV?
Humans.
Yes, that's an important part of HIV.
Great start. Great start.
Archie, what you think? It could be in the most generic form. You don't have to be like real specific.
Us.
Mm-hmm.
African Americans.
Yep. Okay, Kay says straight women. Yes, straight women are contracting HIV at much higher rates than people actually know that are being reported.
Yeah.
But I want to be cautious again about language. We want to say cisgender women or cisgender heterosexual women, because there's a whole nother category of women that are impacted by HIV that don't fall into that particular category.
I want to be politically correct. Again, I've gotten written up once today, not trying to get it twice. Cisgender women are diagnosed with HIV because their boyfriend, their cisgender male partners are on the DL.
Is that a question? That's your comment.
No, that's what they say. That's one of the stigmas around it. That's why cisgender women are contracting HIV, is because their cisgender men are on the DL or they swing both ways.
Yeah, that's a misconception and that's a stereotype. And, we're not going to say that some of those things do not transpire, right? We don't know what happens in people's sexual bedrooms. And even from my personal experience, even when I do a sexual health history, people are not always forthcoming about their health histories because they're embarrassed, because we're asking them to lay out everything about themselves to me that you never met before. Maybe we talked on the phone a couple times, and I'm telling you to tell me everything about you that's vulnerable and everything about you that society may consider taboo or risque or whatever. And you coming on there with the auspice that I'm judging you for those things, when really I'm not. I just need to understand to have those conversations. Okay, what risks may you have? What risk may you have been exposed to? What options do we have? What things do we need to talk about and discuss? But to, answer your question, yes, that has happened. We know this is a reality, but that's not the only reason that, cisgender heterosexual Black women are contracting HIV.
DJ, did you want me to chime in here?
Yeah, shoot, because we're going to get to the Q&A in a second.
Yeah. So according to the CDC, in 2019, 69%, that's like 70% of the new cases of HIV were diagnosed among men who have sex with men, without putting any labels on it, just men who have sex with men. So that's 70% of the new cases, and that was in 2019. Now, if you break it down in terms of ethnicity, African American men who have sex with men have a 1 in 2 chance. That's a 50% chance of having HIV. Hispanic men who have sex with men, it's 1 in 6. Caucasian men who have sex with men, it's 1 in 16. Right after Caucasian men who have sex with men is cisgender Black women.
Wow.
Thank you.
Wow.
Now, that's according to the CDC.
I thought it when you said it.
And now let's think about why, though. Let's talk about social networks and sexual networks, right? Particularly for communities of color, we most often shop, eat, date, and have sex in the communities and areas in which we live, which means that it's a certain segmented population that's actually like doing a merry-go-round. You're all having sex with each other. You're all dating the same people. You are all interacting with the same body. So maybe she did not have her partner was a man who had sex with a man, but maybe he had sex with somebody that did. And again, because of those sexual networks, it's what it is. What we call in HIV work, that's community virus. That's how everything stems in one centralized pocket, and you can track what those things are looking like, because when you do the contact tracing behind it, you see there's some commonality.
Mm-hmm. And that's one of the reasons why our goal is to get people, number one, aware of their diagnosis, connected into care, on medications, on antiretroviral medications, and virally suppressed, because we have a saying, V equals V, that viremia equals vulnerability. And so when we say viremia, we means the more virus that's in an individual, or you can even say the more virus that's in the community, the more vulnerable the community is. And so to DJ's point, because of the society that we live in, because of the social stigmas that we live in, and our community tends to cluster. And so you might have a higher concentration of viremia in a particular community. And we see that when we look at the data, where the higher rates of HIV is in certain communities. And so if sister so-and-so lives in a particular community, and that happens to be the community where there are higher rates of an STD or higher rates of HIV, higher rates of, you can even extend it to like chronic disease, to like of cancer. So when people eat fresh fruit and vegetables, the rates of chronic disease go up. So we shouldn't be surprised that when those same communities are at a higher risk for having higher rates of HIV, when they have lack of resources, and people don't tend to go outside of that community, particularly to have something as intimate as sex.
And Doc, you look like you had something to say. What you got?
No.
Go ahead. This is the space. This is what we're doing. It's all in your face.
Because it's like one of those. So I never thought about it like that. Okay. I never thought about, so I compared it to COVID-19, how they say certain communities keep having these outbreaks because they keep hanging out with the same people doing the same thing. And because when you said 1 in 2 of African Americans, I work with predominantly African American individuals at my job, and so I'm thinking half of us.
Yeah.
Well, so, but remember that 1 in 2 is for African American MSM.
Yeah.
Not the entire African American population. It's still a higher rate, even though it's less of a population wide. Right. But that's for African American MSM.
I'm thinking about the same gender loving men that I know. So half of us are positive, and of that half, even more of us don't know that we're positive. Does that make sense? So it makes me think, like I lived with high blood pressure for a while without knowing it, and now my doctor says I have it, whatever. So it's living with me. Doc, no offense, but what y'all do is called a practice. When you perfect what you're doing, then you can tell me what I have. I'm just saying. Like I just took my medication because I follow the rules, but I'm just saying. But it's just like I'm flabbergasted. I'm sorry, that's just a lot. Like I thought, truthfully, I knew we was gonna have this conversation, right? I thought this was gonna be, hey, this is HIV. This is how we can prevent it.
Right.
La-di-da. Let's hold hands and sing kumbaya type situation. I did not expect some of the data that I'm getting. Like and me being a part of the alphabet community, I'm thinking about the young people who I mentored, like the young men coming up. And I'm thinking about like, wow, wow. That's the word of the day. Wow.
Arteria, you got something?
I'm not dumb, but I feel dumb, if that makes any sense.
Right.
Mhm.
Because again, like I say, I'm near and dear to someone that is living with this. So when we found out, I was one of those sick people, and so now that you guys are educating me, it makes me think about why he feel the way that he do,
Mhm.
why his train of thought is the way that it is, why he don't go get the help that he needs, why he's not. It's really make you think like, okay, this is why, because of people like me that was not educated on the HIV and AIDS.
Mhm.
So it's really making me think.
Yeah, but I will say though, take pride in knowing that you're taking today to be able to get facts
Yep.
and get information, right? Because support systems are so integral to the success of this thing. Like, I don't care, and I can speak from my own experience. There was no way I would be where I am if I did not have support. It's difficult. Don't get me wrong. It is hard. It's hard to hear that your entire life is about to change the moment that those words utter across somebody's lips.
Yeah.
There are so many different things that we are responsible for doing, but that's part of the problem too, because every onus is put on us. There's never an onus put on the person that may have contracted or passed HIV to me. There's never any onus put on anybody else. The onus is always put on me, and what did I do, or what I could have did differently, and now what am I supposed to do, and these things that I have to do these things moving forward. So I'm saying all that to say, be encouraged that this will help you to support, because now you're looking at it through a different lens.
I know when we found out, I was just like you just said, I was like, well, you shouldn't have been doing what you was doing. So
Mhm.
it
Mhm.
slapped me in the face, but
Yeah.
Yeah. So from the provider end, I can't tell you how many times I have patients who are of the Caucasian persuasion, and they have so much support, and so you wonder. I mean, outside of we know society supports them, right? So I'm not trying to, but
Mhm.
you know that there's a sort of invisible support that they have, right? But on top of that, just immediate support. And I see it, if I haven't seen it, over and over again. And then for my African American patients, it's like the polar opposite. It's like they're dealing with stuff on their own, and maybe there's a partner there that can help support them. Maybe there's a sibling, but that's kind of 50-50. And so so absolutely, it immediately puts a significant burden on the person that like most people, you could go to your friends and say, hey man, I got diabetes, man. I can't be going out to eat pizza every night we go out. I can't drink, as much beer and liquor and wine or whatever.
Mhm.
But how can you go to your buddies and tell them, you know what I mean? Like, so I do think that there's a significant, especially in our community, there's something about our community that does not allow us to be as open and free with each other as other communities that I've noticed.
I agree, but I also think we got to add in the point too about the stigmas and the discriminations based off of HIV transmission, right? So if it's perinatal transmission, it's like, oh, that wasn't your fault, that was out of your control. And by the way,
Right.
perinatal transmission means that it was a child who was born with HIV that was passed from their mother to the child during childbirth.
Right.
Thankfully, we don't see a lot of those cases anymore because we have perfected antiretroviral therapies and changed some birthing practices, but perinatal transmission is more, I would say, more so accepted as a means of transmission of HIV than any other one.
Yeah.
Second thing, then, of course, is it relates to is women, right? It's kind of that same thing where you had no control over this. You must have been raped or something traumatic must have happened to you. You wouldn't have allowed yourself to experience that. The third category would have been blood transfusions, but again, in the U.S., that's not really a factor for us. But again, that's one of those things where it's not your fault. You couldn't have known, these kind of things. So even in those instances, and that's a whole thing in people in the community that people live with HIV, is a discrimination behind how did you acquire HIV? And notice y'all, I said acquire. I didn't say transmit. I said acquire.
Mm-hmm.
So, y'all got any thoughts before we move on to the Q&A? Because I do want these questions to get answered. They are some really great questions. I want to give our viewers a chance to ask some questions. So please hit us up in the comments. I know we're hitting y'all up with a lot tonight, but I said it was going to be tough, and I meant it to be tough, but we're going to get to the end of it. I promise you, there is a light at the end of this conversation.
Yeah.
I'm ready
Like
for
I like to consider myself an educated individual. I love knowledge. I have a ton of books, and I feel like I'm in kindergarten. You're telling me this is a circle, this is a triangle, this is a square. That's what I feel right now.
But you want to know a secret though? You don't really. Most people don't understand the complexities or the intricacies unless this is the work that you do, right? And I'm not saying that to say that people are not intelligent enough to understand them, but we have to look at these things every day and through multiple lenses to kind of address these disparities and look at them through individualized approaches because every person is different. So yes, this is what the framework says, but DJ might not need steps 1, 3, and 5.
Mm-hmm.
He might only need 2 and 7.
Mm-hmm.
And of 2 and 7, 2 might be offensive to him because of his cultural background. So then what can I do to make 2 still relevant and include 7 to make it producive and conducive to him? And ultimately, I'm speaking for me, that's like, how I learned, not just through my own personal experiences, but really looking at stuff like, okay, yeah, this is what the frameworks say. I know what the theories say. I know what the context says. I know what HRSA, the Health Resources Services Administration, says we're supposed to do to deliver this specific service. I got it. But that don't work for him, and that doesn't work for her, and that's not going to work for them, and you have to tailor and tweak it. And the only way we can do that is by doing stuff like this, and that's having very real and transparent conversations to not just educate ourselves, but to educate our peers, to educate our colleagues, to educate our community. If every one person did that, and like I said, being very cognizant of language, because HIV is the only health disparity that we still use the word test when everything else is a screen. Everything else is a screening.
Yep.
But I see we got things, so we're going to jump right into the questions so y'all can get some more of Dr. Thomas's knowledge. So Dr. Thomas, the first question was, can the HIV virus live outside the human body? And if so, for how long?
Yeah, so according to the CDC, the HIV virus, depending on the concentration and depending on the conditions and the temperature and things like that, the surface area, it can live up to several hours. But you should know that in many cases, the concentration is low to negligible, which means depending on, again, if it's dried blood or anything like that, that's a different scenario. But we should just know it's several hours, and it depends on the condition that that's going on in that particular area.
All right. Raphael asks, why is there a stigma or spirit of depression attached to HIV?
Yeah, I think we went over it quite a bit, but again, I think societal, we talked about it, structural judgment that happens as a result of society putting this sort of pressure on our community, and in addition to that, you have the person that's internalizing that. So it's one thing to say someone's hurling a thing at you, right? It's another thing they say, when you throw a rock in the crowd, the only person that holler is the one you hit, right? Mm-hmm. But so we don't, and DJ, I love how you said earlier, like, you don't have to attach what society thinks about you to you. That's what they think. That don't make it true. And it's only when I buy it that it gets to the weight of being depression, anxiety, and things of that nature. But I'm not telling you, it's not easy. It's not easy, especially without the support and the love and of your family and friends. And that's what we need more than anything else. And so we do need that, where people love and support us. And I can tell you, DJ and I worked together for many years, and it makes a world of a difference when somebody has someone there that can help them process the whole information. Because usually when we tell somebody that they're HIV positive, it's like the minute you say that, it's like everything else sounds like womp, 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 womp. So we have to be cognizant of that and know that this person is processing all of these thoughts and emotions that's happening. So just to have someone else there that we know is going to keep this person safe, is going to be able to at least process, okay, wait, there's a medication he has to take. He has to go down to the pharmacy. He has to get some labs done. So this person is getting all the sort of, the alphabets together and things that needs to happen. So that's helpful. So hopefully that was a roundabout way of just saying that it's a lot to deal with, and depression and anxiety is something that we are aware of. And, we believe that it's essential to treat those things along with the HIV, because if you get so depressed where you feel like, oh, life is over, forget about it, well then, so we just can't ignore that depression. Although we can say, oh, but we know why they're depressed. It doesn't matter. We may have to treat the depression in order to treat the HIV, because if you get too depressed, you're not taking nothing. You're not going to, you just dive in your cocoon, and you may even get off into drugs and alcohol, which makes it worse. And then you might get on the vengeful tip. So there's so many things that can happen. And so we, in certain terms of when we're treating HIV, we have a very much of a complete wraparound approach. So we're doing housing, we're doing mental health, we're doing pharmaceutical medicine, we're doing the whole nine, just to be able to get those to move you across that continuum: diagnosis, linked to care, retained in care, on meds, and virally suppressed.
So speaking on that, I had a friend, forgive me if I cry, in undergraduate, one of my best friends, we was each other's support system through school. He came out and told his parents that he was HIV positive, and his mother and his father reacted, don't come around, we don't want to catch it, don't come to the house, don't come around your nieces and nephews. They went to the far extreme. He took his life. He took his life and left a note. And in his note, it said, if I don't have my family, then what do I have to live for? And he asked me to do the eulogy at his funeral. And that was the hardest thing I could ever do, because the family said, I don't know why he did this. Read the fucking letter. Excuse my French. I'm sorry, Ricky. Read the letter. He said, if I don't have my family, then what do I have to live for? So for me, that depression is not my depression, but I was depressed because I lost a good friend. I lost a good friend in a time where I felt like, as Bishop Funnel said, we have Google. Like, don't come around the house. Like, I sit in your living room. Your sofa is not going to contract HIV. Like, I'm sorry. Depression that's my field of work. I like helping people come out of that. And so that kind of rung a bell with me, because those two things, I lost someone who I feel was my rock in college. That was my go-to. That was my support system. That was my ride or die. That was my, we got arrested, what we do to get here person. And I lost that because of somebody's stupidity. And so I try to be there for people. I'm trying to cheer myself up, because if I cry, it's not going to stop.
Well, no, I mean, we thank you for sharing that. But, one of the effects or implications of stigma is isolation, right? Depression is a huge form of isolation. Those feelings, that chemical imbalance, that's exactly what it does. It causes us to isolate. But again, that's a after effect of stigma, especially as it relates to HIV. Isolation is the key component of that. And again, it's to my point about, what I've been harping in on. That support system is so integral, because, like I said, at that moment, your entire life has shifted. Everything that you thought you knew has shifted. And most times you spend so much time trying to educate or re-educate people about things, and like just even having these simple conversations. I think, and I've worked in this field long enough to see people live long, healthy, happy lives and continue to do so if they take the proper steps to do that. But I've also seen the reverse of that. I've seen people that are in their 20s die because they haven't taken medications, and they're diagnosed later. So when they're diagnosed, they have CD4 counts of 2, 1, 2, when the normal range is between 1,000 to 1,500, and you have 2. And unfortunately, it's not the HIV that kills them. It's the other stuff. It's the cold. It's pneumonia. It's whatever is common that we have enough immunity, that most people have enough immunity to just fight off. Those are the things that usually are what kill people. But, there's all of these different facets to that. And I say that to say, as unfortunate as those things are, they are not isolated instances, even in 2021.
Yeah. And DJ, I can also say, and again, Doc, thanks for sharing that. I feel that. I think we also need to get rid of this notion that Black people don't commit suicide, and Black people don't have depression. All you gotta do is pray about it. I mean, no offense, I believe in prayer. I believe in it. Okay, I get the running in here. Okay, now, but God also supplied us with people that went to school for this. Okay, and so, and we should just know that although depression rates are slightly lower in men, but men tend to, when they get depressed, they go there. So they are more likely to commit suicide. So we just have to make sure that, and DJ and I ran programs, and we take it very serious. We had a whole staff. We made sure that people were around them too, and everybody kind of had to come to some senses that this person was safe. And safe is one thing when we're talking about getting the viral load down and getting the person on medication, but safe is also means, his partner is not gonna be violent toward him, that this person is gonna have a place to stay as a result of this diagnosis. This person is gonna not take their life. So all those things play a role, and so it's complex, but I certainly think that we have to take that into consideration, that men who get depressed are more likely to commit or more likely to go through with the suicide.
Yeah, thanks, Dr. Thomas. Next question we have are, what activities are most likely to transmit HIV? So I know we kind of touched on that a little bit, but
yeah. So those activities are primarily at the top of the list is sex, and then you have intravenous drug use. You have blood transfusions, things like that. Now, again, this stuff is low because of our processes that we have in place. But to DJ's point, if you go to another country, those processes may or may not be there to allow those rates to be as low as they are in the United States. In terms of sex, anal sex tends to have the highest rate of transmission, then vaginal sex, and then very, very low is oral sex.
Okay, we talked about that. Can you do oral sex? You just answered that question. How long does it take for symptoms of HIV to show up?
Yeah, so typically anywhere between 2 to 4 weeks. With HIV transmission, you're dealing with like sort of 3 stages. Stage 1 is the acute infection stage, and that happens about 2 to 4 weeks after the person has acquired HIV, and so that those symptoms tend to be flu-like symptoms. So it feels like you have a really bad cold, or even more associated is more like a flu. So you got fever, cough, chills, sore throat, rash. We call it lymphadenopathy. You have like the little knots along the side of your neck. It's called lymphadenopathy. Now, everything I just described, also diarrhea, can happen with the flu. So it really does require that you associate that with a sexual encounter. Wait, I had sex 2 weeks ago or 3 weeks ago, and then now all of a sudden I have these flu-like symptoms. That means it's time for you to come in to get checked. So we have stage one. Stage one is the acute infection where you have the fever, cough, chills, rash, sore throat. That happens between 2 to 4 weeks. Then stage two is what we call clinical latency, or it's the chronic HIV infection. And that can go on for 10 years or more. And the symptoms tend to be close to nothing. So after that acute phase, which is when the viral load is very, very, very high during stage one, the virus comes down. You're still able to transmit the virus, but your symptomatology may be very close to nothing. Then after that, after the 10 years of stage two, there's stage three, which is advanced immune deficiency disorder. And that is when people have not been diagnosed, not on treatment. You get rapid weight loss, pneumonia. You can get severe brain infections. That basically is when you have a ineffective immune system, and you're susceptible to a lot of what we call opportunistic infections. And it's infections that typically people with normal functioning immune systems do not have these infections. So you can get like cryptococcus meningitis. You can get Kaposi sarcoma, which is a skin cancer. It's things that we don't really see amongst people with competent, strong immune systems. So we have stage 1, 2, and 3. Stage 1 is the acute infection within 2 to 4 weeks. Stage 2, clinical latency or chronic infection. You can stay there within 10 to 12 years. And then stage 3 is acquired immune deficiency syndrome.
Also known as advanced HIV infection, because AIDS is a very stigmatizing term because of what we know about in the 80s. So
right. And we saw a lot of that. So I would just say hopefully I look younger than what I really am, but I saw a lot of that when I was in training. And when antiretrovirals came out, or I should say the cocktail came out, that changed the game in terms of keeping patients alive. Now, we do know that even though, and I tell my patients this all the time, is that we are able to keep patients alive as long as they take the medications, right? Mm-hmm. We do know that despite being on the medication, that there is a higher rate of chronic disease as a result of having HIV. And so we need to be more cognizant of making sure that we're treating high blood pressure, treating high cholesterol, treating diabetes, because those things tend to accelerate because of the HIV infection. So while your health outcome from HIV is very low, if you're on the medications, we have to watch you for chronic disease development because those things are higher as a result of the HIV infection.
And also, monitoring renal function, because most of these drugs are metabolized and cleared through the kidney.
Yes.
And as great as they are very taxing on the kidney.
Yes, but I do not want to scare nobody off of.
I'm not trying to scare anybody at all. I mean, the drugs are great, but I'm just saying to that point about
we do have to
being very conscientious about HIV and AIDS and what does that mean, and
that's right.
The steps that you have to take as like I didn't even know until I looked at the literature, like, oh, now I'm considered a long-term survivor because it's been 15 years for me. So I'm like, at that 10-year mark, it's like, okay, well, this person is a long-term survivor. So even thinking about the complexities of the levels of my own health, like having to be very conscientious and choosing a regimen that's like, okay, well, I don't want this in there because I'm looking at what this says. Or, I don't want to take this thing because I'm also taking this thing.
Yes. And DJ, to your point, that's why if we go back to looking at that HIV care continuum, is that having you retained in care is important, so we can check those labs, so we can check that kidney function, make sure that your cholesterol is low, make sure your blood pressure is controlled. Because while we know when you're on that medicine and you're taking it, daily, we know your viral load is going to be undetectable, and that's great. But we have to check those other things that can also affect your mortality and morbidity as a result of having HIV.
Are symptoms different between men and women for HIV infection?
Yeah, this is a good question. Essentially the answer to this is no. What we do know that can be different is women tend to have a lower viral load, up to 40% lower than men. Women tend to have higher CD4 counts. Now, how does that play out? Well, it plays out that you remember we talked about in stage 1 with those symptoms of fever, cough, chills, sore throat. Well, women may not have as pronounced symptomatology within that 2 to 4 week range. So I mean that they may not know that they are sick or they feel ill, right? What I will say is that just having taken care of many women and just having been surrounded by women, they pay attention to everything. So although they may not have the same amount of symptoms, they going to see somebody. Please trust and believe. They're gonna be there right front and center whenever the health center open, they right there trying to figure out what's happening. And so and then many of the women also will tend to help to get the men in. So that's also helpful. But so to answer your question, the differences are negligible with the exception of the fact that they tend to have lower viral loads, higher CD4 counts, which means their symptomatology may not be as pronounced. And so it may delay their access to care or their coming to see the doctor.
All right. Next question was, can animals contract HIV? And if so, are they able to transmit it to humans?
Yeah, this was an interesting question because I'm not a veterinarian, but I will say, I was like, whoa, okay, you got me on here now. But from what I looked up, there's really only one animal that can contract HIV, and that's the monkey. And it's due to its similar genetic makeup to humans. But no other animal to date. There's some studies to say there is some studies that indicate that cows may have a immune defense mechanism. So it's the exact opposite. Their immune system tends to be very defensive against HIV. But to date, monkeys is the only, and not chimpanzees, by the way. So it's monkeys in particular that share the similar genetic makeup as humans. So that's the only animal. No cats, no dogs, no hamsters, nothing.
Go ahead, Arteria. You can ask your question.
Okay, so I have a question. And this is going back to the support system. So I know that you're a doctor on the outside, and I mean by outside as far as the prison system. So what are any HIV or AIDS?
Okay.
HIV and AIDS in the system.
So
okay. I don't know if it was just me, Terry, but you was kind of in and out there for
I missed
a lot of that was.
Mr. Terry, come back again. Come back. Roll it back.
Can y'all hear me?
I hear you now.
Yeah. Okay, so I know that you're a doctor on the outside, i.e., not in the prison system.
Not in prison.
Right.
Okay.
You're not a doctor in prison. Or the people that are living with HIV and AIDS getting in the prison system.
Yeah. Are you asked?
So she's saying that she knows that you're not a doctor in the prison system.
Yes.
So the question is related to care in the prison system, and how is it different, or did I miss that part? Okay, yes. So yeah, that's the question.
So to my knowledge, there should be no difference in how we take care of patients on the inside and outside. In fact, when we were at Cook County, we had a doc that treated patients at the county jail, but also had a clinic on the outside as well. And so, the science behind what we do, the only thing I think might be different is and to be honest with you, you can argue that the care might be better in jail, and I'll tell you why. Because in jail, you control a lot of those social conditions that we talked about that impact somebody's ability to be on medicine and stay on medicine. So I'm controlling all those factors that, because that means Jimmy can't just randomly, go and disappear on us, that lost to care. No, you ain't lost. You right in cell blocks 8. Come down here, down this hallway and take this medicine, okay? We can guarantee that you have housing. We can guarantee you have food. Mm-hmm. Those are things that we can't guarantee when you come in my clinic. I can't guarantee your social condition. Now, we have lots of resources. I don't want to say we have lots of resources on the outside, more resources than we do for a lot of other patients for HIV. But even those, it does not compensate for the amount and all the time we spent on stigma. That does not compensate for that amount, the amount of social pressure that patients are under, and it impacts their ability to take care of themselves, to take the medicine, to eat right, to drink plenty of water, not to use drugs. A lot of patients use drugs to cope with depression. Mm-hmm. Guess what? You can't do in jail. I don't know if you can't.
You're not supposed to.
You're not supposed to. So your access to drugs and alcohol is less. Let's put it that way. So I'm saying you can argue that someone's care is better in jail, not because the medicines are different, but because you're controlling all those other aspects that impact people's care. And to be honest with you, maybe even more so than the actual medicines themselves. Can't take away the science of those medicines, right? You can't take away that. But gosh, those other things play a huge role, because if you don't take the pill, what good is the medicine? I tell my patients all the time, that medicine is great. It's been proven to do wonderful things, extend your life and prevent death and blah, 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 blah. But guess what? If it's there on the shelf, it's no good. And so a lot of the conditions that our patients find themselves in, it really does compete with their ability to take that medicine. And so we're talking about all those social conditions and things like that. So I would argue that if you're in the penal system, you can argue that your care is actually better.
Yeah, I would agree, and mainly because of autonomy. And yeah. I agree with you. That's the biggest distinction is patient autonomy.
Yeah, and while we promote patient autonomy, but sometimes it don't work out for our benefit. And I say our benefit, but
their benefits as well. Yeah,
right, their benefits as well. Yeah.
All right. So next question is, why is HIV always paired with AIDS? And since they isn't one the progressive state of the other, so shouldn't they be classified differently?
Yeah, absolutely. But again, you got a huge part of this population. I mean, this meaning our society, that are ignorant. And they ignorant, I don't mean that to be insulting. I mean that to mean they don't know. And so until we have more forums like this, that we're having really a relaxed intellectual discussion where it's not politically motivated and, but it's just, hey, come on, ask your question. Nobody's dumb. Nobody's stupid. Leave your politics though at the door. If you want to learn something and walk away with more information than what you came in here with, cool. And but it's just that people don't know and they're not aware, and so you're sort of repeating this cycle of ignorance. And then you'd be surprised, some of these very same people that don't know, they go and talk to somebody else as if they know.
Exactly.
And then you don't know nothing, and then you telling somebody else nothing.
And then the other part to that, though, from a clinical lens, is that if a person comes in and they have one of the two categories that gives them a classification of an AIDS diagnosis, even if they improve both of those classifications, that AIDS diagnosis is never removed from their medical record.
That's true. That is true.
And we have been, as advocates, have been fighting for this to change for decades because it's ridiculous. But I do understand the clinical context behind the increased likelihood of those things transpiring again because of the level of compromise of the immune system.
Yeah,
I get it. But that's a huge major factor in why the two are often seen as synonymous, even though they aren't.
Yeah. And and DJ, I wonder too, does is that done also? So, like there are pluses and minuses to anything that's done, right? And so you wonder if it's not also to keep the person, because sometimes you have access to more resources having the AIDS diagnosis as opposed to HIV diagnosis. And so does that help that person maintain the resources that they had, right? That may have allowed them to have went from AIDS back to HIV. So then once you take those resources away, now housing, food, all the things that help support the person, you take those things away, they might move back to AIDS. So you wonder if that plays a role here too. So you have to ask yourself, do you really want to, is this dog worth your fight?
Yeah, but I also would argue if we look at things now and the level of resources that have been diminished over the past few years because of previous administrations, we don't see that trend.
Right.
In fact, it's the exact opposite.
Right.
This is the lowest rates and the highest rates of virus suppression that we've seen in people living with HIV in years, despite everything else that's going on.
That's true. Yeah, true story.
Last question, and then we're going to move to the last segment for the evening is, what can we do to alleviate stigma? So we talked about this a lot. Dr. Thomas, real quick, about 30 seconds.
All right. I think we got to have more forums like this. We just got to get it out, talk about it. And I think we got to use, untraditional methods of communication. And so that might mean, I'm talking about like really, really like going to nightclubs, going to using these forums, going to like Urban League, and really talking to people with resources. A lot of legislators need to know a lot of the information that we're talking about now. Because see, what happens is we're having this discussion now, and the people that hold the purse strings to make huge impacts don't know nothing about the conversation that we're having now. And yet they're the ones that's being held responsible for making choices around what resources do we have to take care of our patients. And so we got to definitely look at untraditional resources to educate the community.
All right, thanks for that, Dr. Thomas. So we're gonna move into, we done said all of these things, we done harped on all of these really hard and negative and depressing moments. I want to move to some positive things. Let's talk about the hope for tomorrow as it relates to HIV. So the first thing that I want to introduce is a concept that's called, at least for people living with HIV, is U equals U. So that's the counterpart to Dr. Thomas's V equals V, right? So undetectable equals untransmittable. Now, clarified, disclaimer, this science only relates to sexual transmission of HIV. I want to be very clear on that. Very clear on that. But what that context means is that if a person living with HIV is taking their medication every day and has a suppressed virus, there's a less than 1% chance that they can sexually transmit that virus to someone who is HIV negative.
Correct.
So that's first thing. The second thing that we're going to talk about really quickly is the National HIV/AIDS Strategy. A huge tenet of that is that the goal of this strategy is to reduce disparities in HIV infections in the population by 2030, right? So Dr. Thomas, tenets at NHAS, really quickly.
What was that now? What'd you say?
NHAS, the National HIV/AIDS Strategy. Quick overview.
Oh, yeah. Okay, so this strategy basically sets out an agenda for us to reduce new infections from happening. And it's really the agenda to end the HIV epidemic. And one of the things that we're excited about is there's a medication, or I should say a program called PrEP. And, the cornerstone of ending the epidemic means stopping, or part of it means a major pillar is stopping the new infections from happening. And so PrEP has been, touted as 99% effective in preventing HIV. We have 2 medications that's been approved through the FDA, Descovy and Truvada. Truvada right now is just for cisgender women, and Descovy is for trans women and men. So we're excited about those about those medications to help prevent. Now, I hate to go back to the challenging part, but only about 18% of the population that could benefit from PrEP is actually on PrEP. So there's a lot of growth that needs to happen, and I think part of it is initially when PrEP came out, it was targeted for just the LGBT community. I think that was probably a misstep. But now we're moving the advertising toward a more broader audience. That if you're having sex, you're at risk for HIV, and you should consider PrEP as part of that.
Last thing about hope, or one more thing, and then I'm going to go, is the 90-90-90 strategy, right? Yeah. And so what that means is that 90% of people who are living with HIV will know their status and be diagnosed. Of those same individuals, 90% of those people will be prescribed and commit to antiretroviral therapies. And of those same individuals, 90% of those individuals will be virally suppressed with the goal of ending the HIV epidemic by 2030.
Yeah.
So, there is hope at the end of this tunnel because 2030 is around the corner.
DJ, I gotta say, DJ and I were at a conference. Was it almost like right before the pandemic, right? When we went
it was the year right before.
It was the year right before. I mean, it was so exciting if y'all can just imagine, it was signs everywhere, ending the epidemic. And you had all these different programs throughout the country, and we were all excited. And Dr. Falsey was our keynote speaker, right, DJ?
Yes.
I mean, and he had us riled up, man. It was really, really exciting. And again, DJ, we got to get that excitement back. I'm glad you mentioned this as part of the Hope for Tomorrow, because we need that excitement back. We can't lose that feeling of walking through the auditorium and the hotel, and you saw these signs, ending the epidemic. We've got to do it, and we can do it. I think there's some learning lessons with COVID. And, we shouldn't use COVID as an excuse. We should use COVID and say, hey, now we're bigger, we're stronger, we're faster. So now we know what to do. We made a lot of missteps, so we can learn some things from COVID and use that for accomplishing the 90-90-90.
Yep. And my last point is that, again, HIV and AIDS. People living with HIV are living as long, if not longer, than people who are not living with HIV, as long as they are committed to their antiretroviral therapies, are consistently seeing their doctors, and making sure that they're making conscious healthcare choices. So I wanted to end with that because that's important. Yeah. HIV is not a death sentence anymore. No. It does not have to be.
No.
And we have to communicate that there are people that are living every day longer and longer because of antiretroviral therapy.
Yeah. I'm surprised that that's even still, part of the narrative. And again, I got to get out of my bubble, but because, that's no longer the case. If you're on this medication, I can guarantee you're going to die from something, but it's not going to be HIV.
All right. All right, fam. We're going to thank Dr. Pete Thomas for coming and hanging out with us on this evening. Me and Arteria learned more than we thought we was going to learn. Thank you so much for sharing your knowledge. Guys, join us again next week, 7 o'clock, 7:15 Eastern, 6:15 Central. If you have some more show topics, okay, I went real country. Some more show topics. Email them to us, nocluetheshow@gmail.com. Give us your feedback, nocluetheshow@gmail.com. Follow us on IG. Follow us on Twitter. Follow us on Facebook. Follow us on Instagram. Follow us on
YouTube,
Twitch, podcast, Spotify, Apple. Follow us. All right. If you in Chicago, follow them all around. Just follow them around. And as you follow them around, no, I'm not gonna go there. I'll do that for next time. All right. We love you guys. We'll see you guys next week. Next week's show topic is the old church versus the new church. Arteria is bringing it next week, y'all. Woo! It's gonna be amazing. All right. So we'll see y'all again. Until next time, be good. We love you. Just when you thought you had life figured out, you realize you have what?
No clue.
All right, see y'all next week. Blue Fi.
Thank you.